for a quick break for everyone. I just want to welcome everyone here today for our Children's Center for Neuroscience Research Seminar. I'm Stacy Heilman. I'm the Associate Vice Chair for Research in Department of Pediatrics and the Interim Director for CCNR. And we are looking forward to 2021. I think 2021 is a lot of new beginnings, and our CCNR Children's Center for Neuroscience Research will really be revitalized, and we're looking forward to an exciting year and launching it off with today's seminar. And I've asked Dr. Klin to introduce our speaker today.
Thank you very much, Stacy. It gives me a tremendous amount of pleasure to introduce you, Nicolas Abreu. I happen to have met Nick during his undergraduate year, so I think our history now goes back a few years back. But Nick is a clinician scientist whose career goals are going to be dedicated to advancing genetically mediated therapies for rare monogenic neurodevelopmental and neurodegenerative disorders. Nick, even though he's young, his academic career is already 17 years old. He started at Yale. He completed his bachelor's degree, magna cum laude, at Yale in biology and cognitive science. During that time, he spent a full year as a Fulbright in London, studying cognitive science as well and doing studies. He conducted studies in autism at the Yale Child Study Center, which is how we met. He went on to get his medical degree at Harvard. And after that, he was an intern and then resident in pediatrics at NYU, and then back as a resident and clinical fellow in neurology and neurodevelopmental disabilities at Harvard and Boston Children's Hospital. And for the past 2 years, completing a fellowship in gene therapy at Nationwide. I was very, very, very excited when I was introduced or reintroduced to Nick, because the opportunities that we have here at Children's and at Emory in leveraging our clinical volumes and our clinical service for the purpose of science is huge. And his interest and his experience, both on the gene therapy side and on the neuroimaging side, on the development of biomarkers, outcome measures for the study of highly penetrant monogenic conditions, is something that we all as a system would like to invest in. So with no further ado, my great pleasure to introduce you to Nick.
Hello all, and thank you very much for having me hosting me during these past 2 days. It's been wonderful to meet such a vibrant both research and clinical community here. And thank you for the opportunity to share the work I've been doing for the past 1.5 years as a gene therapy fellow. So a bit of an introduction about what my specialty is. I completed my neurodevelopmental disabilities training, which if any trainees are interested in learning more, I will plug a recent paper where I reviewed the training path in neurodevelopmental disabilities in the journal Neurology. And neurodevelopmental disabilities is a 2+4 training model after medical school, where you do 2 years of general pediatrics and then do 4 years of subspecialty training in child neurology, adult neurology, and neurodevelopmental disabilities. It is different from child neurology in so much as child neurology is a 2+3 year model, with you do 2 years of general pediatrics and then 3 years of subspecialty training in adult and child neurology. And neurodevelopmental disabilities has its own board through the American Society for American Board of Psychiatry and Neurology, which I would sit for this coming September after completing my board certification in pediatrics and neurology with special certification in child neurology. After doing postgraduate medical training, I went on to doing a neuromuscular genetic therapeutics fellowship at Nationwide Children's, which is a primarily clinical research-based fellowship. I dropped the neuromuscular part, at least learning some of the basic principles of gene therapy through the neuromuscular realm, but really trying to dedicate my future work in neurodevelopmental genetic therapeutics. So the goals of my talk are twofold. One, to introduce or better understand the principles of adeno-associated virus-mediated gene replacement therapy for monogenic neurodegenerative disorders of childhood. And thereafter, outline some novel biomarkers and clinical outcome assessments for two specific conditions, namely Batten disease and Sanfilippo syndrome, and their potential use in clinical trials using gene replacement therapy. So I'd like you all to meet James. James I saw in clinic a few months ago in neurology, and after a period of normal development, in kindergarten, he began forgetting his numbers and letters of the alphabet. He then developed behavioral outbursts and started to have motor difficulties characterized by difficulty swinging a baseball bat, having a hard time catching balls, and had a hard time handwriting. He then developed seizures, to specifically generalized tonic-clonic seizures, and initial laboratory evaluation was unrevealing. He had biochemical assays for inborn errors of metabolism and a microarray that didn't show a specific genetic diagnosis, and ultimately underwent a brain MRI. On the right, you can see his MRI from around this time, showing cerebellar atrophy in the posterior fossa here, and thereafter went for ophthalmological evaluation because he was running into objects in his field of view. On ophthalmology evaluation, this is not his autofluorescent image, but was pulled from a representative case in the literature. But for the sake of discussion, let's say that this was James. He displayed a ring of increased autofluorescence displayed by the white arrowheads and mild diffuse peripheral hypoautofluorescence consistent with the diagnosis of a bullseye maculopathy. So we're starting to get a picture of what may be going on in this specific, in James. And when we think about bullseye maculopathy from an ophthalmological perspective, you can think of both primary ocular diseases as well as systemic diseases that might be underlying the finding. There are also some acquired effects, but in this child with evidence of behavioral, motor, and cognitive decline with seizures, start to be worried about systemic diseases, specifically Batten disease. You can see that there are other items in the differential, but the constellation of findings is pretty consistent with Batten disease. So what is Batten disease? It comes in many different names and many different forms. So Batten disease is also known as neuronal ceroid lipofuscinosis and is collectively can be considered as the NCLs, or the abbreviation of neuronal ceroid lipofuscinosis. It is a group of disorders caused by genetic variants in multiple different genes and is a autosomal recessive lysosomal storage disorder that leads to buildup of ceroid lipofuscin, ultimately a lysosomal storage material that leads to neuronal injury and ultimately cell death. It primarily affects the central nervous system and retina, but peripheral organs like the heart and the peripheral nervous system can also be involved. And prior to detailed genetic understanding of Batten disease, it was classified by age of onset, either infantile, late infantile being 2 to 5 years of age of onset, to juvenile being after 5 years of onset, and then also some adult onset diseases or subtypes. There are 13 genes associated with Batten disease or neuronal ceroid lipofuscinosis, and they're called CLN1 to CLN14. It is confusing because you're alternating the letters around, but it stands for ceroid lipofuscinosis neuronal type 1 through 14. And CLN9 is not an independent genetic subtype because it was only classified based on certain phenotype information. So ultimately, you have 13 genetic subtypes despite the range from CLN1 to CLN14. On the bottom right, you can see what these autofluorescent what the autofluorescent neuronal storage material looks like. So you can see these big yellow storage granules, and then on the right on Luxol fast blue stain, you can see more of the storage material within neurons. So going back to James, We thought, or I should qualify this by saying all of this work was done by a local neurologist, and we only saw him after genetic diagnosis. And that really plays a big role into his diagnostic odyssey. The primary neurologist attempted to obtain genetic testing, but because of insurance issues, could not obtain next generation sequencing panel testing. So instead went additional biochemical assays within Batten disease. Of the different subtypes of Batten disease, some you can measure enzymes, namely PPT1 or CLN1 disease, as well as TPP1 or associated with CLN2 disease, and that enzyme testing in blood leukocytes was normal. He underwent a skin biopsy or procedure showing classic features of Batten disease, namely on electron microscopy, curvilinear bodies, and fingerprint profiles. However, they went forward and did another biochemical measure for Batten disease, namely vacuolated lymphocytes, but none were identified. Still not with a specific genetic diagnosis. Ultimately, insurance was able to approve panel-based testing, and he was identified to have two likely pathogenic variants that were inherited in trans, or on one copy on each of the chromosomes, in CLN8, thus providing a genetic diagnosis of CLN8 disease. So what is the CLN8 protein? Unlike some other types of Batten disease, CLN8 is not a soluble or a specific enzyme that we can test for like CLN1 and CLN2. For CLN8, on the right, you can see CLN8 as the green transmembrane protein, which exists on the membrane of the endoplasmic reticulum, being able to ship lysosomal proteins from the ER to the Golgi apparatus, and has a crucial role in lysosomal biogenesis, getting lysosomes where they need to go in order to properly break down material from the cell. Without the adequate ability of the CLN8 protein to ship or shuttle the lysosomal proteins to the correct place, you end up not being able to have proper lysosomal function, leading to the lysosomal storage disorder and the storage material that you can see in this similar buildup from prior images. So we met James. He went through a whole range of diagnostic tests, ranging from ophthalmological evaluation to MRI. I didn't discuss his EEG features or neuropsychological features. We talked about different biochemical assays that can be done, and we reviewed ultimately the genetic testing that was most helpful in providing confirmatory diagnostic testing. We're using it as, so James is a very good example of how children with Batten disease have a long diagnostic odyssey that is common within many rare monogenic neurodevelopmental disorders. In a preliminary review of 10 individuals seen at Nationwide Children's Hospital, we sought to look at a more prevalent subtype of Batten disease, namely CLN3 disease, how often or how long it took from symptoms to diagnosis. You can see here that CLN3 disease, it took a median of 16 months from first symptoms to diagnosis. Now, CLN3 disease is a juvenile onset Batten disease, where oftentimes children between 4 to 6, 7 years of age start to have vision loss, and cognitive issues come later. So ophthalmology is a really key piece in not only CLN3 disease, but in the whole diagnostic process of Batten disease, children with Batten disease, in terms of making sure that we can go from symptoms to a genetic diagnosis. And here you can see that every one of our 10 children ended up going through ophthalmology before ultimately being identified to have CLN3 disease. In the bottom left, you can see what kinds of genetic testing our cohort received. And the majority of children received a next generation sequencing panel testing, as well as some still receiving some single gene testing, and one individual receiving familial variant analysis given a positive family history. Which gene panels were selected? You can see that the majority of individuals with CLN3 disease received a retinal dystrophy gene panel that was ultimately diagnostic, and then epilepsy and Batten disease panels were used less commonly. Ultimately, I think there are many issues that need to be addressed in terms of early and more efficient diagnosis of children with Batten disease, here using CLN3 as an example, and using a story of James as a case in point that being able to mobilize or having access to genetic testing is crucial if we're going to be able to adequately identify children with rare monogenic neurodevelopmental disorders. Things like insurance barriers and having subspecialists outside of neurology who are comfortable with genetic testing is critical. And so having partners in genetic counseling, as well as in other departments who are able to appropriately interpret results and knowing where to send panel testing is critical. And then less emphasis on skin biopsies and biochemical measures may be better principles governing future diagnosis. Going back to James with CLN8 disease, now that he has a diagnosis, what does it mean? At least in the majority of individuals with CLN8 disease, or in the majority of individuals with Batten disease, there are no currently approved therapies, except for CLN2 disease, where there's enzyme replacement. However, for James, there's preclinical work suggesting adeno-associated virus serotype 9 gene therapy could be helpful for treatment of underlying CLN8 disease. In work done at the Sanford Institute as well as the Nationwide Children's Hospital, they have shown that mice with CLN8 disease or CLN8 mutant mice can have an improved survival as well as improvement in behavioral deficits, as well as improvement in histopathological features after treatment. Now, it's postnatal day 1 or P1 in this one study. You can see on the left how CLN8 mice in blue have a survival of about 10 months, and wild type or normal mice are in the light blue, surviving well past 24 months, and that gene therapy treated CLN8 affected mice in, wild types in black and light blue is the treated mice, that they approach wild type survival. The route of administration is key to understanding if there's how there could be benefit from gene therapy. And in this preclinical study, they used intracerebral ventricular injections or infusions, similar to what's currently done for enzyme replacement for CLN2 disease. So taking a step back from Batten disease, what is gene therapy? Gene therapy is the introduction, removal, or change in the content of a person's genetic code with the goal of treating or curing a disease. There are many different ways of performing gene therapy, and generally it is broken down into in vivo versus ex vivo gene therapy. Ex vivo is one that I have less experience with, which requires harvesting progenitor stem cells from a patient, and then in a cell culture separate from the individual, infusing or introducing typically a adeno-associated virus, or sorry, a lentivirus, with the goal of providing a transgene or the gene of interest, the normally functioning gene, into the cells that have the abnormal copy of the gene, and with the whole goal of introducing the gene of interest directly into the DNA of the progenitor stem cells. Once that's done outside of the body, and those cells are genetically modified, they are then reintroduced into the patient using their own cells, but then are genetically modified with the plan of engrafting into the human, and thereafter be able to produce cells ongoing with the gene of interest. That is distinct from in vivo gene therapy, which I'm more familiar with, looking at different types of viral vectors to introduce into humans directly the virus containing the gene of interest that then go into non-differentiated cells like motor neurons in the case of spinal muscular atrophy. And then the transgene or gene of interest exists outside of the host's DNA and then continues to make the protein of interest. There are cases in the neurodegenerative world of both currently being approved for treatment. Zolgensma or anasemnogene abeparvovec is the most commonly known within for treatment of spinal muscular atrophy, both in Europe as well as in the US. And then Limeldi, it has recently been approved for conditional treatment of metachromatic leukodystrophy in Europe. Here's just another way of looking at gene replacement therapy. On the top, this is for Zolgensma. You can see the expression cassette or the type of genetic information that is packaged into the box being the viral vector that then together get delivered to the patient in vivo gene replacement therapy to be able to provide the gene of interest and ultimately get the protein that the individual is not appropriately producing. I'm just talking about gene replacement, but there are other ways of packaging different types of genetic information to turn certain genes on or off or regulate RNA function. On the right, you can see the seminal work done by Dr. Mendel and colleagues looking at use of anasemnogene abeparvovec for treatment of infantile SMA or SMA type 1. They looked at 15 individuals, of which 12 were given the high dose of 2 × 10^14 vector viral genomes per kilo, given IV. And you can see the event-free survival of those in red being the natural history controls. Event-free survival was defined as absence of use of a ventilator for permanent ventilation for more than 14 days. And the vast majority of natural history controls did not meet the, ended up having some event or having significant respiratory needs, such that only 20% were event-free by 2 years after onset of symptoms. Whereas in the gene therapy treated group, everyone in the second cohort was independent from permanent ventilation. Very, very exciting and has revolutionized the field such that now we have IV gene therapy for a neurodegenerative condition like SMA. Gene therapy has now moved into clinical practice, and even more so thanks to the groundwork of having nusinersen or Spinraza as a way of early treatment of spinal muscular atrophy. Zolgensma has been further boosted by early and rapid identification of children with spinal muscular atrophy via newborn screening. So in Ohio, we have access to newborn screening for SMA, and therefore children with positive newborn screen or those with clinical suspicion for SMA, maybe later in onset prior to, that were born prior to onset of newborn screening for SMA, get identified. We then proceed with genetic confirmation. And if they're less than 2 and meet a series of pre-screening measures, we then consider them for gene replacement therapy. It is clear that every child is not necessarily a candidate for gene replacement therapy. And there are still major hurdles within the field of gene therapy to think about how can we actually treat more individuals than we currently are, and how can we be more efficacious. So at least in the US, there's a cutoff of FDA approval for children less than 2 years of age that currently is being actively discussed about whether older children may benefit from treatment from anasemnogene abeparvovec. And then things like pre-existing antibodies to AAV9 pose a major barrier to individuals getting gene replacement therapy. And then of the other things to mention, individuals with severe disease like significant weakness at screening for gene therapy or permanent ventilation are all reasons that SMA gene replacement therapy may not be considered. And so thinking about how which groups and how to best administer gene therapy remains a major issue, not only in neuromuscular medicine, as well as in other areas where gene replacement is moving forward. Moving from gene replacement therapy for neuromuscular conditions into gene replacement therapy for the central nervous system, things to consider are administering the therapy to the right place. So not only the right brain regions, but also the right cells in those brain regions. And a lot of that has to do with vector design and transduction effectiveness or efficiency, of which major work in the preclinical side to see what is the proper design for all those things, plus route of administration is critical before moving forward with a clinical trial in gene therapy. The other issue is the right time. So in SMA gene therapy, we're learning more that the earlier you treat, namely in the first couple months of life, the better the outcome, and also if pre-symptomatic or minimally symptomatic, the better the outcome and potentially the fewer side effects, namely less liver toxicity. How much that holds true to other areas of neurology, namely neurodegenerative or neurodevelopmental processes, remains unknown, but very likely the earlier you treat, likely the better the outcomes, and is a major factor in clinical trial design. The other thing that I'd like to focus more on is measuring the right way. So are you using the right tools to actually assess for improvement in functioning based upon what you know about the underlying disease? So just like you measure cell size, not with a 12-inch ruler, you have to make sure that when you're designing these trials that you fundamentally understand the disorder and how the disorder changes over time so that you're appropriately setting up your clinical trial for success. There are two different aspects of this I'd like to talk about. One is on outcome measured assessment and the other one is on biomarkers. Outcome assessment is really about how does the individual feel, how do they function, or how do they survive? And there are different ways to gather that information. You can look at clinician reported outcomes, you can look at parent or observer or teacher reported outcomes, you can look at direct patient reported outcomes, you can look at performance measures on things like walking a certain distance. All of them have different value and can be used in different ways in clinical trials. So what about outcome measures in CLN8 disease? Well, unfortunately, because it's an ultra rare disorder, we have no outcome measures or fundamental understanding of disease progression, making it a major limitation in moving from the preclinical, exciting preclinical data into a clinical trial. And so one of my main efforts in the past year and a half was how can we then design or better understand the natural history of CLN8 disease to inform clinical trial development. So CLN8 disease can also be considered a late infantile variant of Batten disease, and typically with age of onset between 2 to 7 years of age. Looking at University College London mutation database, the majority of individuals there were classified as a late infantile type, but you can see that there's an overrepresentation, I would say overrepresentation because of a founder effect. There were many Finnish individuals described with CLN8 disease, but typically they were older with minimal visual problems, and they were classified as a epilepsy progressive with mental retardation, which again, poor term, at least in current diagnostics. But EPMR seems to be a very different type of Batten disease than the more typical late infantile form. And this is related to the identify of the quote unquote Finnish variant, this C to G change at the 70th coding DNA position, and that individuals with this slowly progressive later onset disease seem to be homozygous for this specific mutation, which is critical in understanding, again, natural history and clinical trial development to make sure that those are stratified before considering them all as a homogeneous group. In an effort to better understand CLN8 disease, I sought to define group trends in the rate of decline in neurologic function in this specific cohort of children with CLN8 Batten disease. Initially was looking to do in-person assessments, but with the COVID-19 pandemic, moved to a combination of telehealth and in-person measures. We focused on both baseline assessments as well as follow-up over 6 months and 12 months after initial visit. And we used two major scales that were applicable across telehealth and in-person visits, including the Hamburg scale, a previously developed clinician-reported outcome measure in CLN2 Batten disease, or one that also has a late infantile onset, that scores range from 0 being no functioning to 6 being normal functioning. You can see that these are pretty large differences in functioning between each score level, and these are rated by an expert clinician familiar with Batten disease. We also used an adaptive measure based on parent report, or the Vineland. Here you can see baseline data that we collected on 6 individuals. And in our cohort, it fit nicely within that late infantile group with symptom onset between 3 and 5 years of age. And soon after symptoms developed, seizures came soon thereafter. Vision was a later onset of, developed later, in contrast to CLN3 disease, where vision oftentimes happens first. And there are a mix of different kinds of symptoms at symptom onset. Our cohort were impaired, ranging from pretty profound impairments in adaptive functioning, ranging from 21 to more mild impairments in global functioning, but still significantly impaired up to 68. We then used parent reports at a single visit to extrapolate back changes or progression of symptoms using that 0 to 6 scale, or the Hamburg scale. This is just a review of how in red, there's one patient who is slowly progressing and the others have a more significant and profound decline in neurological functioning or motor language functioning over time. Again, this is just a sum of the score on the left of both motor and language functioning. We then were able to calculate an annual rate of decline, which is key to figure out what is going on with the natural history controls in determining a treatment trial. And so without treatment, we were saying in this very small cohort, at least a median decline of about 1.4 units per year once they became symptomatic. The whole idea is then to describe what an untreated control decline would look like, or a curve of decline, so that with treatment, you can see if there is indeed benefit or change from that curve. So what is the path forward? We already have evidence in other types of Batten disease of moving forward with gene therapy clinical trials. Within CLN3 and CLN6 disease at Nationwide Children's Hospital, they have moved forward with phase 1/2 AV9-based intrathecally administered gene replacement. Now, while that is exciting, there's still room to grow even in these specific conditions. As individuals with more mild disease, you may not be able to capture change or treatment response just because, as you remember, the scales in those previous measures were pretty large steps. So being able to tell, okay, is there something as a 2.5 on this Hamburg scale? What if someone's having a little bit of clumsiness, but we're not really able to capture it on this Hamburg scale? Similarly, another validated measure of Batten disease functioning is this Unified Batten Disease Rating Scale out of the University of Rochester. And there's one specific clinician, this is also a clinician reported outcome scale, and within all the ways that the clinician is supposed to assess physical symptoms, there is one on gait ranging on a scale of 0 to 4, which you can see is a bit subjective, just as the Hamburg scale is. And so can we develop better measures of assessing for outcome of motor decline in Batten disease? There's some evidence from Europe suggesting that you can use a performance outcome measure like the 6-minute walk test. And they were able to successfully show decline, at least with some degree of heterogeneity, as patients with CLN3 disease, again, a juvenile form where vision loss is the most common primary symptom or early symptom, there's decline, but 6 minutes is a long time for children who are 4 or 5 years of age to walk, who may have behavioral or attentional difficulties. And in this specific study, they allowed a physical therapist to hold the hand of the individual walking for that entire time. That could bias their results. So we sought to develop novel ambulatory outcome measures, looking at 3 different assays. One was a 50-meter time test, much shorter than what can be much shorter than walking for 6 minutes, and really being able to do a maximal ability. So that included running, not limited to just walking. The second tool we used was a gait right walkway, or looking at spatiotemporal gait analysis, the pattern that captures footfalls and pattern of foot positioning as someone walks over this carpet. And third, we looked at a norm-referenced measure of balance for individuals ranging between 4 to 21 years of age. Here, I'm only showing data from the walkway, which we're still in the process of analyzing the other data, but we were able to get 6 individuals of 9 to have valid passes on the specific walkway, with about 4 passes per person. So then we averaged the results and calculated for each individual a mean velocity, mean step length, and mean support base. You can see on the left what was pulled from the literature about normal for each individual age group, and you can see on the right what the spread or breakdown of our cohort was. These individuals included both, was majority of children with CLN3 disease, and 1 individual with CLN8 disease, showing that overall there was a slower speed in children with Batten disease, smaller step length, and a wider support base, consistent with what we see clinically being both Parkinsonian features as well as ataxic features. Now, is this going to be the end-all be-all for clinical trials and gene therapy for Batten disease? No, and ultimately restricting outcome measures just to looking at ambulatory individuals is exceptionally challenging. We had many people who could not complete testing, and we ran into floor effects because of this. Due to this, we're looking at broader skills, and something that I'd like to bring with me going forward that was able to capture children who are minimally functioning to maximally functioning on single scales, something like the GMFM and other things that are being developed, like a gross motor outcome scale for neuromuscular patients, initially developed at Nationwide Children's, but with the ability to be translated to other populations and other centers. So with some discussion about outcome assessments in Batten disease, I'd like to move into biomarkers in a different neurodegenerative disorder. Biomarkers distinct from clinical outcome assessments are a defined characteristic that is measured as an indicator of normal biological processes, pathogenic processes, or responses to an exposure or intervention. This can include molecular, histologic, radiographic, or physiologic characteristics, all as type of biomarkers, but do not assess how an individual feels, functions, or survives. They can be used for many different things, from monitoring or surveilling an individual, like a hemoglobin A1C, all the way to diagnostic, as well as predictive. And so there are different ways that biomarkers can be used. For my interest, I really am looking for biomarkers to assess disease progression in hopes of seeing if there's then treatment responsiveness after, say, gene therapy. Moving into another autosomal recessive neurodegenerative lysosomal storage disorder like mucopolysaccharidosis type 3, This is a disease that affects anywhere between 1 to 2 per 100,000 live births, and the majority are related to biallelic variants in 2 genes, namely SGSH and NAGLU, leading to buildup of heparan sulfate. When there's glycosaminoglycan buildup, especially in the brain in Sanfilippo syndrome, there's associated neurodegeneration or cerebral atrophy, ultimately with marked behavioral and cognitive deficits, ultimately leading to early life death in these individuals. There are other features like dysmorphic facial features and skeletal involvement, but can be most often is characterized as a neurodegenerative process. There are AAV9 gene therapy trials currently underway with very exciting interim data recently presented at the World Symposium. But even with these clinical trials underway, there remains that neuropsychological assessment in individuals who are low developmental functioning combined with change over time with different ages can be challenging to have a single neurodevelopmental assessment for these individuals. And therefore, clinically relevant and objective biomarkers accessible across all chronological and developmental ages remains critical to ensure clinical trial success. So I'm really looking for surrogate endpoints, ways to complement neurodevelopmental testing to assess whether treatments can or cannot be effective. In this project, I look to identify regional brain volumes sensitive to change over a period of 12 months in children with MPS IIIA and IIIB compared to healthy controls. Previous work done by the Minnesota group, Elsa Sapiro and Chester Whitley, previously showed that there was cerebral cortex reduction in individuals with MPS IIIA and IIIB. However, looking at multiple other brain volumes was not performed, and we sought to see if there was global reductions as described as is described qualitatively on MRI reports within children with Sanfilippo syndrome across development. I piggybacked off of a previously completed prospective natural history study done at Nationwide Children's Hospital that recruited individuals 2 years and older with a confirmed genetic diagnosis of MPS IIIA or IIIB, which are nearly clinically indistinguishable, who had neurologic symptoms at enrollment. Those that were not able to participate in at least some testing and where an LP or sedation could not be performed for MRIs were excluded from the analysis. And here you can see in the individuals with MPS III, they underwent MRI at enrollment or at the initial baseline visit 1, and then 12 months later. We compared this to MRIs gathered from the PEDS MRI database housed at the NIH. And there we looked at scans at baseline and 24 months later, just purely due to the protocol, trying to get as close to 12 months as was possible, matching by age and sex. For our MPS III patients, they underwent imaging in a 3 Tesla MRI using T1 weighted sequences with a slight thickness of 1 millimeter. And we did automated segmentation with visual inspection thereafter to ensure appropriate segmentation using a longitudinal processing stream of 7 predefined brain volumes. That included the cerebral cortex, the cerebral white matter, the subcortical gray matter, the corpus callosum, the lateral ventricles, the cerebellar white matter, and the cerebellar gray matter. Of the 25 individuals initially enrolled, you can see that we had a number that were excluded due to an intracranial hardware, lack of follow-up MRI, and those that had analytic failure, leading to a final group of 13 individuals with two interpretable MRIs. Here's the main slide showing that within each subject, we calculated an annualized change in segmented brain volume. So you can see this is a mean of each individual, each control, their change from their follow-up MRI compared to their baseline MRI, how many cubic centimeters changed between that time, and then just given the difference in follow-up or time between initial scan and follow-up scan between between controls and MPS 3, we then calculated an annualized change. So if, for example, we did a scan at month 0 and then 18 months later in the controls, just because of that difference in protocols, we then made sure to account for that 18 months being different from the 12 months in our controls, and that's how we calculated the annualized change. You can see the major difference in individuals with MPS 3 in cerebral cortex compared to controls, or a difference of 141 cubic centimeters per year. And really there's this loss of cerebral cortex in the MPS 3 compared to expected cerebral growth or cortical growth in the controls. That's true for cerebral white matter, subcortical gray matter, corpus callosum, and cerebellar cortex, with a compensatory increase in the lateral ventricles compared to compensatory increase in the CSF or lateral ventricles compared to controls. The cerebellar white matter did not come out to be significant. Here's just an example of what that looks like within each individual patient. You can see for the cerebral cortex, brain volume on the y-axis and age in months on the x-axis, with each individual patient plotted out with their own cortex volumes. The individuals with MPS 3A are shown in red, with 3B in blue, and in black are the controls. And you can see the controls an expected increase in cortical brain volume over time. And regardless of if it's MPS 3A or 3B, you see a decline. We then did a visual inspection to see if there was difference in how individuals with MPS 3, how their brain volumes changed depending on their baseline age at enrollment. And you can see on the left are the gray bars showing the younger individuals, less than 8 years of age, compared to the white bars, those who are of older age at enrollment, that there was greater reductions in cerebral cortex, greater reductions in cortical gray matter, and greater compensatory increase in CSF volume or lateral ventricular volume compared to the older individuals, suggesting that if neuroimaging is to be used as a biomarker, that these are probably most useful in a younger cohort of individuals where you're more likely to see declines or reductions in brain volume over time, whereas the older individuals, you may not be able to capture small changes because they're just overall not changing less, at least if you were to introduce treatment. So fundamentally, I'm driven to try to provide incredibly necessary treatments for these devastating neurodevelopmental and neurodegenerative disorders, capitalizing on the amazing advances within gene therapy. And we've reviewed how gene therapy has moved beyond the neuromuscular clinic into clinical trials for neurodevelopmental disorders, and require the appropriate use of clinical outcome assessments as well as biomarkers to ensure that these clinical trials are successful. We reviewed some cases of, or reviewed CLN8 disease and how there's measurable decline using the Hamburg scale in neurologic functioning in this disorder, and that gait assessment could be used as a window into early neurologic dysfunction, with the caveat that it may not capture, it just doesn't capture the whole range of motor functioning across individuals with Batten disease. Finally, we concluded on how children with Sanfilippo syndrome demonstrate global reductions in supratentorial gray and white matter, as well as cerebellar gray matter compared to healthy controls, and that limiting potential biomarkers of neuroimaging in this disorder just to the cerebral cortex misses the opportunity to utilize these other brain regions as potential surrogate endpoints. All of these studies were limited by small sample sizes, and the CLN8 study relied on parental recall bias, which I fully admit to, as well as limited direct observations, though we're trying to use video and previous videos to try to help correlate those changes in neurologic functioning with real-time assessments. With the motor outcome work, It was primarily based on a clinical sample, which may not be representative of a larger population. And we're still working to define the phenotype of the individuals that we tested, namely the neuropsychological profile and vision profile, to match their motor functioning with other measures of their neurologic status. And finally, I didn't discuss this in detail, but in the MPS III study, the controls not only had differences in terms of time between MRI, but also in terms of signal strength. So the individuals with the controls were collected on a 1.5T MRI scanner across multiple sites, and all those with MPS III were done at nationwide on a 3T scanner. There's also an assumption of linearity, which may not very well be true, that we calculated when we used the annualized change in brain volumes. So with that, thank you very much for your time. I have my email here, and happy to take any questions or comments.
Thank you so much. That was really interesting. And I'm sure we have questions, and we already have one pop up from Dr. Joyner. What cell types are targeted in the mouse model with AAV gene therapy for Batten disease?
I believe we have pretty good so one, I will caveat that I do not do basic science myself, and I could be wrong here, but I will look this up afterwards. I believe AAV9 is good at targeting both neurons as well as glial cells, which, just in review of the work coming out of Cornell using AAV-RH10 for CLN2 gene therapy, it seems like they're focused more on neurons and less on glial cells, which both seem to be important in Batten disease.
Great, thank you. Any other questions, please feel free to put in chat, or also you may unmute yourself if you'd like to ask directly. One thing that I was just thinking about as you went through, because I think one of the common themes is earlier is better. The earlier interventions, the better way to measure if there are changes, because I think as you progress, it's intuitive that it's, becomes too late for intervention. So what is the possibility for newborn screening? Are you a proponent of that? What are sort of the pros and cons around that?
Yes, I think it's revolutionized spinal muscular atrophy and many inborn errors of metabolism in terms of changing both just completely transforming outcomes. I think when we have the chicken or the egg issue, as many are familiar with Fragile X syndrome, that many of the clinical trials that have failed with Fragile X, there's a question of if we're treating too late. And many have been proponents of newborn screening for Fragile X syndrome, mainly for, or at least one reason would be for earlier recognition and potentially clinical trials that could start earlier and be more likely to show benefit. In general, I think for CLN2 disease, where we have enzyme replacement, really hope that people are moving forward with newborn screening, but that is not my area of expertise, and I don't know what's involved. Certainly, there's everything from doing next generation sequencing on dried blood spots, with a lot of work coming out of Utah on that, as well as enzyme assays. So it's a burgeoning field, and one that I would defer to other experts in terms of what the status is.
Okay, thank you. See, I'm looking to see if anyone's unmuting themselves or like to ask a question. I actually have one more question. I think that it's coming out of the fact that we've got Georgia Tech right down the street, and so we've got lots of engineers and computer scientists and people like that to collaborate with. When you were talking about the gait analysis and just talking about the limitations with that, it occurred to me, I wondered if there was an opportunity to use sensors or send the kids home in their home environment to detect more subtle changes. Have you thought about that, or is there any work being explored in that area to really assess outcome measures on a more micro scale?
Yes, and not that I'm currently doing. I know there's one PhD physical therapist here who is doing, who has, you put me in touch with that researcher that's currently being done. Not that I know in Batten disease, but I think one thing that I was looking at for this project, but was not actually able to get off the ground, was doing video-based analysis. So there's work currently being done on AI and facial recognition and its ability during telehealth visits to provide phenotypic information for someone's mood, and could very well be translated into, I have this video of a person walking down a hallway. Can we then specifically go into those videos, isolate each individual joint, and perform a video-based kind of quasi-kinematic analysis, assuming that you have the right video or environmental conditions to adequately capture those features. But there's, I think, a lot of utility with, especially in the COVID-19 pandemic, of using videos more quantitatively.
It's so fascinating. Looks like we have another question. Go ahead, by your doppelganger. The person who would like to ask a question on parent-identified outcomes, please go ahead.
Yes, Larry Skagel here. Yeah, what wonderful talk. And I'm just curious, as you know probably well, in Parkinson's and certainly in our field of autism, that we're tended toward getting from parents what they think is important when we think about outcomes. I wonder if you could comment on that.
Sorry, could you repeat the question?
The question is the role of parents and the parent-identified outcomes that are important to them.
Yes, I think certainly the FDA is looking for what outcomes are actually meaningful to the individual. And when we have children with developmental differences or disabilities, the parent is an incredible voice in capturing what changes are actually meaningful to them. So I think so far, I have not delved deeply into this. There's some, like the PEDS-QL is one thing that I've been looking at, as well as the Vineland, but the Vineland is not necessarily capturing the overall picture of how the parent's feeling. One other aspect of this is something that our PTs, I've learned from the PTs at Nationwide, is the PD or PEDI, the Pediatric Evaluation Disability Inventory, more as a motor measure, but looking at functioning over and above everything. And that's also a parent report measure.
I was just going to add one thing. We recently were awarded an R1. I think I've mentioned this to you, Nick. An R1 focusing on performance-based automated outcomes, actually biomarkers for motor development in the first year of life, together with collaborators in 2 other universities, and we're very happy to share that with you.
All right, well, thank you so much, everyone. I'm afraid we're out of time, but thank you so much to Dr. Abreu for this wonderful talk, and thank you all for joining us, and we'll see you next time.